Mariam Al-Faqi, lecturer and vitreoretinal consultant in Ain Shams University, Cairo, Egypt. And the aim of this presentation is to understand the retinopathy of prematurity, making screening much easier. I have no financial disclosures. Most of the images are original ones taken by the author and used after patient consent, except for few ones for which references are added. Retinopathy of prematurity is a potentially blinding, preventable disease affecting the immature retina of preterm babies. Immature retina is retina which is not completely vascularized, easily missed on examination, but when you look meticulously, you will see that the vessels are not reaching the end of the retina. This retina with time can turn into retinal detachment, causing blindness. How this happens? The loss of the hypoxic drive after delivery causes the vessels to stop growth. After a while, this retina, which is avascular, turns into hypoxic retina and produces vascular endothelial growth factor, which is phase 2. Progressive production of vascular endothelial growth factor leads to ROP changes going into neovascularization with progressive production of transforming growth factor beta. The new vessels turn into fibrovascular proliferations and cause retinal detachment, which is the start of the phase 3. So by going through these stages, the retinopathy of prematurity can turn from stage 0 into total retinal detachment. But there is another pattern where the pathology starts very aggressive from the start and goes directly into retinal detachment without going through the previous staging. To understand this, we have to understand the zones and classification of ROP. We have the first pattern, the classic pattern, going into the stages. This is described in 3 terms. If there is plus or not around the central area, looking at the vessels going from the disc to the vascular-avascular junction, how the end, this is the stage, and where the end, this is the zone. So what is the plus disease? Plus disease is dilatation and tortuosity in the vessels within the central area around the disc in 2 or more quadrants, like the images we see above. If you are query about it, you have to follow up the case after 3 days. If the vessels get more dilated and tortuous, this is actual plus. What is the stage? Following the vessels to the end, how do they look like? If we don't have any pathology, this we call stage 0. If we have a demarcation line, we call this stage 1. A ridge, we call this stage 2. If new vessels are formed, this is stage 3. And if retinal detachment is not involving the macula, this is 4A. Involving the macula, we call it 4B. And if we have total retinal detachment, we call this stage 5. What about the zone? The more posterior the pathology, the less the zone. So zone 1 is the central area surrounding the disc and the macula. The 2 disc diameters surrounding it, we call this the posterior zone 2. The rest of zone 2 to the nasal aura and completing the circle, this is zone 2. And a small temporal area is called zone 3. Looking at the RETCAM images, we draw a circle with its radius being double the distance between the disc and the fovea. Superior, inferior, nasal, temporal, this is the end of zone 1. Anything outside this is zone 2. We don't image zone 3 by RETCAM. Clinical examination using a 28 diopter lens. When you put the disc on one side of the lens and you look at the end of the other side of the image, this is zone 1. If you want to get to zone 2, you have to roll the eye with a scoop, as you will see. By rolling the eye, what you can see here is zone 2 and the pathology is in zone 2. So where is zone 3? To get to zone 3, you have to go to the small temporal wedge seen here, which we get to it by indenting at the ora serrata. The 2 to 3 disc diameters close to the temporal aura, this is zone 3. So to summarize how we examine our cases, we look first at the plus, there is a plus disease here, and then we roll the eye in all the quadrants. In each quadrant, what is the zone, what is the stage? Temporal was stage 3 in zone 2, inferior stage 2 in zone 2, and now nasal, this is stage 0 in zone 2, and we take the highest stage and the least zone, so this is stage 3, zone 2 with a plus disease. Don't forget that you have another pattern. As we said before, there is an aggressive retinopathy of prematurity that goes directly into retinal detachment. Aggressive ROP has a prominent plus disease, as we see. You can have those collateral loops, you can have hemorrhages, extensive ischemia, flat new vessels, and finally you can have vessels going far periphery to the aura but with extensive ischemia in between, and again the flat new vessels appear here in the fluorescein angiography. This has to be treated immediately before going into retinal detachment. So why we need to treat those cases before retinal detachment? Because treating before retinal detachment can preserve the fovea and allow a 20/20 vision like this child who can easily follow and fixate the target. Treating later on, after retinal detachment, there is no fovea and thus the vision is much worse. So the preferred practice pattern in ROP is the screening. How we do the screening? We have to get the eye fully dilated with a mydriatic or a cycloplegic to which 1% phenylephrine is added. If you don't have 1%, you can use 1 cc from a 10% phenylephrine on either of the bottles to fully dilate the eye. Then we examine either with an assistant or with the mother putting the baby on her lap, and she will be our assistant after swaddling the baby to allow the baby to be more comfortable during the examination. As you can see in this video, this is the way we swaddle our babies. We prepare an indirect ophthalmoscope, a scope and a speculum, and a 28 or a 30 diopter lens for the examination. And we do our regular examination. As we said before, we look centrally at the plus disease, and then we roll the eye in the 4 quadrants to see what is the stage of the ROP and where is the pathology, which zone, and we take the highest stage and the least zone, and this is our pathology. If we check RedCam images, we have to look on the pupillary dilatation. Poor dilatation is sign of plus disease. We look centrally around the disc for the plus disease, and again we follow the vessels from the disc to the periphery and check which stage and in what zone. The least zone is at the end of zone 1, starting zone 2, and with stage 3. So this is stage 3 with plus zone 1 to zone 2 pathology. When do we follow up those cases? At 4 weeks post delivery or 31 weeks post menstrual age, whichever is further away to get the start of phase 2 where the pathology starts. Who we screen? Screening criteria differ according to the NICU management, so it differs in different countries. In the more developed countries, the screening criteria are much lesser than in the less developing countries due to the better NICU staff management. And don't forget that cases which are outside the screening criteria but have multiple comorbidities are also screened. What are the principal risk factors? Those are the low gestational age, low birth weight, prolonged exposure to supplementary oxygen, and fluctuations in oxygen. And don't forget that maternal diabetes is one of the risk factors despite the baby being of a high birth weight. What do we do? If we examine a case and we found it needs a treatment, we have to treat within 48 to 72 hours. What are the cases we treat? If we look centrally and we have a plus disease, and whatever pathology in zone 1 we have to treat, plus and stage 2 in zone 2 we have to treat, stage 3 in zone 2 we have to treat, and if we don't have a plus but there are new vessels in zone 1 we have to treat, and finally with aggressive ROP, and again within 48 to 72 hours. How we treat? We either do laser or we give anti-VEGF. Anti-VEGF is more superior than laser in aggressive ROP because you don't have to do aggressive treatment and because of the risk of skip lesions with laser. While on the other hand, if the case has a high ridge, which is fibrous, indirect laser ophthalmoscopy can be a better option to all the avascular retina not hitting the ridge to allow the spontaneous release of the fibrous element without causing a crunch phenomenon. If you do not find an indication for treatment, you have to divide your case. Either it is a type 2 pre-threshold, which is at high risk also, so you have to follow up very closely every 3 days, or it is less risk according to the zone you schedule your follow-up visits. During the follow-up, you have to make sure that the caloric intake is good, the oxygen saturation is stable without fluctuation, the general condition is good, which allows the spontaneous regression of ROP. So to summarize, if you have a case of premature baby, you have to check if it is within the screening criteria. We check the screening date, and then at that time the NICU staff have to call us for an examination, or if the child is discharged, they have to make the parents sign an informed consent that they will get at the time of the examination and take their phone number. When the child presents for the examination, we have to fill this form. This is the screening criteria up here, and this is the actual criteria now at the time of the examination, and then we fill in the examination data. If there is plus, what stage and what zone, and then do we have to follow up or we have to treat now? Thank you.